recorded.
Starting from scratch. Okay, good. So the title of today's talk is going to be taking care of your heart health. Okay, and if you have any questions, it's going to be very informal. It's going to take about 30 minutes, and don't hesitate to interrupt and ask me questions. Okay. I am a cardiologist. I've been in practice for, I don't know, about 15, 20 years. I do mostly basic sciences and mostly teaching. I think, Wendy and Lisa had asked me to talk about things that are kind of dear to our health. I think hopefully this will be one of many that we could participate in. And so the outline for the talk is going to be, I'm going to start with a case presentation of a heart attack. It's actually mainly for lay people. So it's going to talk about very basic introduction. I think for Karen, it might be too boring. But I'm going to talk about symptoms of a heart attack, chest pain workup. What do you do if you have chest pain? And risk factors. And the most importantly, I'm going to talk about prevention. What can we do to at least do our best to lower our risk of getting a heart attack? Some of them, most of them should be evidence-based. There's some aspects of my practice that's a little different than what's currently accepted. Just letting you know. So I think what motivated me to talk about this is a few years ago, I was at I got a call from his wife telling me that Chan Yoon had passed away. Do you see yourself, Jay, in the slide?
I see that.
Yeah, you that's not you. Chan is actually in front. So Chan is he was a dear friend of mine, and he had gone to he was only 51 years old, and he had no past medical history. He was very healthy, non-smoker, no significant family history of coronary disease. He was in perfect health. Actually, his wife said that he had just completed his first marathon at the year of his heart attack. He was in Japan working for Boeing, and during the meeting, he complained of some epigastric sort of like nausea and stomach pains. And some flu-like symptoms sounds like, and some, they thought it was more of a gastroenteritis. So he went to his hotel room to sleep it off, and he didn't actually come down for dinner. So, but they assumed he was sleeping it off. And next day, when he didn't come back to the conference or meeting, they found out that he was dead in his hotel room. He had an autopsy done there. It's a part of a business trip, and so if since he died at work, they had to make sure that it was an autopsy. So it turned out that he had a acute coronary thrombus in one of his arteries. They didn't say which artery, but it was a classic heart attack symptoms. And so hello? Sorry if I'm going too fast or too slow, okay? So heart attack is caused by a thrombus. So there's many different types of pain. I'm going to talk about it. There's a narrowing of the arteries, and then you don't really get a heart attack unless you get a complete occlusion. And complete occlusion is caused by like a bursting of a coronary plaques, and then causes basically a blood clot within the coronary arteries. These coronary arteries are the blood vessels that feed the heart, and the coronary vessels actually are very small for our body, and they actually come off the aorta, and they traverse outside the heart, and what we call epicardial space, and then they go into the muscles of the heart. And for a vast majority of our humanity, I think these coronary arteries did okay. They served this purpose. But these vessels they're relatively small vessels, and they can get blocked off. And so this is one of those clots that he had happened. And so here's a very basic vocabulary of what's going on. Coronary artery disease is very prevalent, as most of the coronary artery disease is silent. And this is where you have over a course of years or decades, there's a plaque that builds up inside the artery. So plaques are sort of like a cholesterol buildup, but also with inflammatory component as well. And it turns out that even if you were to take autopsy samples of young soldiers in their 20s, you could see an evidence of coronary plaque building up. And over a course of decades, and in certain cases with a familiar hypercholesterolemia or other sort of a family history patients, these blood vessels can become thicker or narrower and narrower, and then it could cause angina. This is where it's like having a Charlie horse of your heart, where the blood supply is insufficient to meet the demands of the muscles' heart work because of narrowing. As you know, if you have a narrowing of the blood vessels, it takes a lot more energy to force that blood through that narrowing, and there can be what we call coronary ischemia. That in itself, you could feel it, and it's very common, but that in itself doesn't cause heart attack. It's just like a Charlie horse in the heart. But the heart attack is when these plaques get disrupted. It breaks off. And these cholesterol deposits tends to be very highly inflammatory. So when they are exposed to the blood stream, they initiate a blood clotting cascade, which then causes basically a clot within the coronary arteries. And then when that happens, the blood flow completely stops. And then the downstream tissue that is supplied by the blood vessels become first ischemic, and then infarcts. It causes a death of the downstream muscles. Did I make it actually clear? And when that happens, what we do is that cardiologists perform this procedure called coronary angiogram and a percutaneous PTCA. Basically, we call it the ballooning and stenting. Basically, we go in through either the vessels in your arm or in the groin, and then we thread a catheter up into your coronary arteries. And using a radio opaque contrast, we can see whether these blood vessels, where the blockages may be. And I think Clifford will know, he's a radiologist, so this is a technique that was pioneered by the radiologist. And what we can do since the 1980s is that we actually use a balloon to just squish open that plaque and just smush open those blockages. And if there's any clotting or anything like that, we could also suck out the clots as well. And this technique can be also adapted for acute strokes as now. You can actually do this for people having a sudden strokes. And then the second part is involved in putting a stent. Stent is like little metal mesh that we put up to keep the blood vessels open. And that we can do this within the setting of a heart attack. And this is an example where what happens in a coronary cath lab. The slide A shows a acute thrombus. This is one where it's a 99% blockage, but you could see the downstream flow. Oftentimes, when you actually go in a setting of a heart attack, there's no downstream flow. This one is like 99% occluded, so 1% is enough to supply the blood vessels. But it can be completely blocked off where you have a sudden cutoff, and you can see there's no blood vessels after that blockage. And then the B is where what it looks like after we actually put a balloon in. Based on the coronary angiogram, I can't see the stent, but presumably that clot was squished open, and then somebody put a stent over it to keep it open. Okay, that's what happens. And really, the important thing in the setting of a heart attack is that this coronary angiogram gets done immediately. We have this thing called door to balloon time, And so we try to keep that within a reasonable amount of time, usually less than an hour. And so once you have the symptoms of a heart attack, you really should get to the hospital as quickly as possible and try to open it up. Because if you don't open it up, it could be a bad news. So cardiology is one of the few fields where everything is emergency. So you really have to, when you have a sudden ST elevation MI, it's one of the few fields where an emergency room doctor in a community hospital can actually activate the system, and then the acute MI team gets involved, and there's no decision. It's just there's no cardiologist involved. It's just once you activate it, it's a train that starts, and then the patient ends up on the cath lab table immediately because you want to make the decision as quickly as possible. So it's a pretty interesting. I've seen a lot of positives, but it's better to have a what do you call cry wolf rather than a delay in treatment. So basics of the heart attack is that it's a very common thing. It's not as common as it used to be. If you look in the 70s and 80s and 60s, this is how middle-aged men used to die. But even now, the heart attacks occur every 34 seconds. About 600,000 people die each year of heart disease. But even if you survive the heart attack, the really bad outcome is that you can develop a heart failure, because once a heart has infarcted, the heart has a very minimal ability to regenerate or repair. So you end up with a big scar, and is a number one cause. It's the main cause of heart failure in the United States. And heart failure is an epidemic in America, where about 6 million people have the heart failure, and the life expectancy after first diagnosis of heart failure is about 5 years. It's giving you an idea. It's equivalent to leukemia. So heart attack is dangerous not just because you die from it. You could die sudden death. It's a very common presentation of sudden death. But even if you survive it, if the treatment is too late, you could end up with a heart failure, which will cause, which could still cause death later down the road. And the scary thing about heart attack is that, just as in Chan's case, heart attack can be the first symptom of atherosclerotic heart disease. It could be the first manifestations. However, and also a heart attack can present in a heart attack with a chest pain. But another scary version is where in 50% time, it presents with a sudden death as well, where you just drop dead. Usually, a heart attack is preceded by unstable angina. So if you talk to people who have survived a heart attack, it's not like they were in a perfectly good health. They may have been, but there's always some sort of prodrome 1 or 2 weeks prior to a big event. And I think I want to kind of highlight some of that, so that if there's something that happens, we can actually be aware of that. Because even though people say it comes out of the blue, if you actually talk to people who survived it, there's always something prior to a big heart attack that should have warranted some attention. I think maybe, I can't speak for Chan, but maybe he had some kind of tingling of something going on, maybe a week or two before, maybe a month before. And this is really hard, because that same month, same week actually, I had another friend from medical school. He's a cardiologist, and he died in his call room taking a call for cardiology. And I just wonder, like, you're a cardiologist, you don't know the symptoms of a heart attack, but it unless you pay attention to it, you could easily miss it. Anyway, sometimes the heart attacks are preceded by unstable angina. It's a medical emergency. It's a pain at rest with minimal exertion, and usually lasting maybe 20 minutes or maybe more. Heart attack is something that lasts more than an hour, more than 30 minutes. These unstable angina can come and go and come and go. So there's always some, I like to think that there's some prodrome before a massive heart attack. There's always something going on that people usually ignore. And oftentimes it could be a pain with mild exertion. For instance, like, suddenly for the past month or so, a couple of months, they can't walk, 2 blocks or climb stairs. And oftentimes, I had one case where I had a patient of mine her husband came with her, and then they were about to leave, and the husband kind of lingered. And I asked him, like, why, you know, can I help you? And he said, oh, by the way, it's probably nothing, but every time even like recently he was having sex and he was having pain with sex. So I could have made a joke out of it, but I asked him, like, how long was it happening? He said, oh, not that long. Maybe not that long. And that was for me a kind of danger sign. And I sent him to a stress lab, which he failed and ended up getting a 99.99% coronary left main disease. So that's one example where if he hadn't, usually the husbands don't show up with a wife appointment. So when they come, he knew he had something to say, just said it in a kind of weird way. But the important thing is that he knew something was up, but he couldn't put a finger on it. And it was very recent onset. And then the thing that's dangerous is crescendo pattern, where it's brought on by less and less activity, and then it gets more and more severe, and it tends to last longer. Oftentimes, people typically have like few seconds of chest pain. That's usually nothing, but it gets longer and longer. I think if it lasts more than a minute and then it goes away, gradually comes back, and then if it lasts longer, that's something that you should consider as a medical emergency and seek medical attention as quickly as you can. Um, and um, and then the symptoms of the chest heart attack is just unstable angina is where things are kind of about to the clot. The way I think of it is the clot is about to form. It forms and it gets cleared, and then forms get cleared, and then there's these microparticles that get embolized distally, and then you're getting small microinfarcts. But like a big thing hasn't happened yet. Okay, but unstable angina can become a massive heart attack. So it is a medical emergency. You need to go seek care, and we treat it as if it's a heart attack, a real full-on heart attack, because it can really, within minutes or days, it can turn into a massive heart attack. Heart attack, on the other hand, symptoms of heart attack or unstable angina, it can be, typically we think of it as a chest pain. It turns out that our muscle cell, our heart pain fibers are not very precise. It's not like the pain fibers of our fingertips, and so we have hard time describing it sometimes. But classically, it's chest heaviness and tightness, and in certain cases, it can be crushing pain, and that makes it easy. When somebody goes, "I'm having crushing chest pain," you get an EKG, it's easy. But really, the difficult part is when it's just it's like it feels not right. It feels like somebody's pushing on my chest or somebody's sitting on my chest. It's not always that classic crushing chest pain. And oftentimes it's intermittent. It can come, can go, it can come and can go. And oftentimes, I am convinced that it's preceded by new exertional symptoms. That oftentimes, if you go and actually listen to the patient, there's always something preceding this massive heart attack. There's always something that's new that was brought on by exertion, and then it would go away with rest. And then it's associated with these. It can radiate. It can radiate to the back. Oftentimes, an upper back ache, and sometimes it radiates to the shoulders. You can radiate to both arms, left or right. And sometimes people describe it as arm heaviness. And then you could actually radiate to the jaw. It's interesting because I had reflux, and reflux feels similar way. I mean, I was convinced that I was having a heart attack, but when you have reflux, you have a kind of burning sensation in the chest, and then you have this like really awkward pain in the jaw, radiates to the jaw. So sometimes even I can tell that it was hard to tell. Sometimes it could be like heartburn pain, and it can radiate to the neck, jaw, and you just gotta have to. But the thing is that when somebody tells you, when I try to walk for past week or so, and then my jaw hurts, then you have to think that that could be a cardiac pain, even though they may not have the chest pain. Anything that's exertional, we have to take really seriously. Exertional as in brought on by exertion, and it's associated with sweating, cold sweats, night sweats, shortness of breath, difficulty breathing, nausea, vomiting, fatigue, and dizziness. Usually, sort of cold sweats and shortness of breath. Sometimes people actually have urge to defecate for no reason. And so you can have some gastrointestinal symptoms, and some symptoms of just something being not right, really profound cold, sweating. The really scary thing is that diabetics tend not to experience these typical chest pains. And many of my diabetic patients may have felt some gastrointestinal vague symptoms, maybe nausea, but diabetics often feel nausea at baseline because they can't digest very well. And so it's hard to tell whether with diabetics, it's really hard to pinpoint when the heart attack started. And oftentimes it could be just kind of vague, shortness of breath or just vague feeling of malaise can be cause of symptoms of heart attack. Basically, if you have a heart attack, I think it's important thing is minutes count, right? You can't, every minute counts because every minute goes by is a loss of myocytes that will never come back. So you need to call 911. And oftentimes in the setting of a heart attack, the heart can stop, go defibrillate. So if you're having chest pain, you must not drive to the hospital because I don't know how many patients I know that I see in the trauma center because what happened was they were having pain and they were driving to the hospital, or they start driving and then they pass out. And so when you think you're having, just be safe and call, either have somebody drive you there or call 911 and have an ambulance. Now, heart attack symptoms in women. Women tend to be protected from heart disease earlier in life, but they tend to develop a little bit later. But when they do get it, they tend to do poorly. And there are many reasons for it, but I think a lot of it is because the symptoms are more subtle, so they may seek attention a little later than men. They tend not to present with crushing chest pain. And so for women, it's still number one presenting symptoms of a heart attack is still chest pain, but it may not be crushing chest pain. It could be just tightness, maybe chest burning even, pressure. But oftentimes the key differentiating from reflux would be that it was preceded by, maybe a week or two by exertional symptoms. And the pain, oftentimes it can also present in the absence of chest pain. It's not common, but it does happen. And it could be just shoulder, upper back, just as if somebody's like a very sore back, but they haven't done any heavy lifting, something. And then it tends to be, it was like back pain that is brought on by walking, something very atypical. But 50% of humanity is women, so who's to say this is atypical, right? This is more typical. But one of the associated with the same symptoms, but oftentimes it's vague symptoms of indigestion. But one of the striking things for me is that women are likely to experience unusual fatigue, some unexplained profound fatigue, maybe a week or two prior to heart attack. That seems to be very common among women. Oftentimes women are so busy taking care of the kids and family and whatnot, they tend not to complain about it. But I'm sure there's something there. Okay. And then again, let me, oops. I don't know exactly what I did, but so the heart attack assessment. The problem with medicine is that this is actually tricky because we know which people have angina. And people with angina can have chest pain for years and even decades, and they won't turn into a heart attack. Yes? Hello? I thought there was any questions, but we still don't know, despite decades of research, which coronary plaque will crack and cause a heart attack. Okay, and if somebody could figure that out, they will win a Nobel Prize. But nobody's actually figured that out. Okay, that is the really the holy grail of medicine. I used to think, I was taught when I was in fellow that the plaques that are narrow, that causes stable chest pain is the one that are causing heart attacks. But based on autopsy results, it's clear that some of them are not like that. There's no correlation. The plaques that rupture, what we call vulnerable plaques, are lipid heavy, but this is not something that we routinely test for. There's no technology right now that's available that's been proven where we could actually tap everybody and look for plaques narrowing that will cause future heart attacks. So we don't really know. Okay, and so that's why our workup or risk assessment is relatively primitive. And so basically, there's no test that will accurately predict if and when a heart attack will occur. There's no test. Even the stress test that you might have heard of will predict whether you have a narrowing somewhere, but you could have a perfectly normal stress test one day and you could still die of heart attack tomorrow. There's no there's no test that predict that. Okay, what the stress test does predict is degree of narrowing, extent of ischemia of that narrowing, and if those narrowing were to go down or have a heart attack in those areas, whether you survive or not. But what it does, what the stress test doesn't do, is whether that narrowing will actually rupture and cause a heart attack. We don't know. We don't have a technology. So, but still, the most of the technology that we have is basically looking at ischemia, right? What Clifford has, there's coronary CT and calcium. It's all about looking for narrowing that we can see. So it's a surrogate for, it's not a perfect test. It's like a surrogate for, looking for vulnerable plaques, but we don't have it. So we have a really good test for looking at narrowings, stress test with perfusion imaging, coronary calcium scoring, and coronary CT angiogram. I only put it controversial because they're really gold standard. If you see a narrowing, it's there, right? But it's controversial because they don't predict whether those narrowing will be the ones that will cause heart attacks. Okay, so in we just had a recent study called ischemia that's turning cardiology on its head. Really, we used to say if somebody had chest pain, we go in, we would just open up if there's a narrowing. It turns out that that doesn't do any good, and the kind of new paradigm is kind of leave the sleeping dogs lie. And if there's some acceleration of symptoms or something else is going wrong, then we go in and try to open up whatever blockages are out there. So there's no role for these tests in actually asymptomatic cases. So our cardiology board exam will be completely redone because of these recent tests. So there's no role at all for symptomatic pain. So if you're not having chest pains, kudos to you because you don't have to worry about it. That doesn't mean that you're not going to die of heart attack tomorrow. It's just that there's no test under the sun that can give you whether it's going to cause find a bad thing or a good thing. There's no test for these tests. But if you have accelerated angina, exertional chest pain that's of recent onset, that's been only happening for less than 4 weeks. Okay, even if it's very mild, that is indication that something could be going wrong. It's a harbinger of something bad to happen. Especially if there's a crescendo pattern, you gotta really get to the hospital, not to the hospital, but try to get a cardiologist within a week to make sure that things don't fall out. Things just go bad. Okay, so and then if you have these symptoms, the stress test and coronary angiogram can tell you whether there's actually a plaque that's actually grown and about to burst. Okay, and then if these non-invasive tests suggest ischemia, or maybe you could just go directly to coronary angiogram and have a cardiologist actually open up blocked arteries if they find it. But right now, at least, the new paradigm is that if you're not having accelerated angina, if you had angina forever, or or you're asymptomatic, there's really no role for looking for trouble, because it turns out that with America you could find something, but it's just like having a mammogram at a young age. You might find a lot of things, but it doesn't mean that you're going to be saving lives, because there's going to be a lot of false positives. So I'm going to talk about coronary artery disease risk factors. Is it okay? Let me know if I'm going too fast or too slow. So the disease risk factors are this. They're non-modifiable ones, mainly age. As we get older and older, we're gonna have heart attacks. Sex, men, the first heart attack tends to be within really remarkably early, narrow time frame, about 55 years plus minus few months. And then women, first heart attack happens to occur around 65, literally within plus minus standard deviation of like a few months. And then genetic background. Basically, if you have a family history of premature coronary disease, for a father younger than 55 or mom younger than 65, that counts as a family history. And that is a pretty significant risk factor for heart disease. And there's some rare people who have these familiar hypercholesterolemia, and you're at risk for having a heart attack at age 30. But those are incredibly rare. Then there are modifiable risk factors. Number one being tobacco, obesity, high cholesterol, high blood pressure. These are all defined by classic epidemiology studies in Framingham Heart Study from the 50s. Type 2 diabetes, a diet can do it, and lack of physical activity. And then another modifiable ones would be systemic rheumatoid inflammatory diseases like lupus, psoriasis, and rheumatoid arthritis, and chronic kidney disease. I put this in under modifiable disease because now you have medications to treat that, against that. The thought here is that chronic inflammatory disease, like lupus and psoriasis, can kind of activate immune responses that result in atherosclerosis and plaque growth. And then chronic kidney disease is a really high risk factor for vascular calcifications and all kinds of vascular complications, including neck and the coronary arteries. So those are modifiable to a degree. And then there's a female specific ones that people don't really talk about. But and basically, there's a condition called pregnancy-associated hypertension, preeclampsia, and eclampsia. Basically, it's clear that people who have these syndromes during, when they're giving birth in their 30s, is a pretty high predictor risk factor for future cardiac events 10, 20 years down the road. So, if you have something like that, you have to consider that you are at higher risk of developing a heart attack later on. And then people with gestational diabetes is a harbinger of a true diabetes. So it's a marker for early premature coronary disease as well. Polycystic ovarian kidney disease and early menopause can also be early menopause. You can bring your risk of heart attack by up to 10 years. So these are female specific. And in women, there's also a thing called mental stress and depression can also be a part of coronary artery disease risk factors as well. And of these, certain things can be modifiable. Tobacco and sudden rise in blood pressure, like say somebody who's kind of relatively sedentary and decide to go do weekend warrior kind of things. That sudden rise in blood pressure can really trigger a plaque rupture. So oftentimes people who have heart attack are suddenly sedentary guy who just decide to go weightlifting or do some treadmill, and that could actually trigger some acute rise in blood pressure and can cause heart attack. So not only are these risk factors for long-term coronary disease, they can actually be trigger, like tobacco and sudden rise in blood pressure, and also inflammatory stress, like inflammation associated with surgery or influenza can be a trigger for heart attack event, not just a atherosclerosis. So I like to show this because this is a relatively old thing, but this is a relative contribution of different risk factors. Okay, so the biggest risk factor that we have best estimate for is high cholesterol. So if you have total cholesterol over 200, LDL of 160, or fasting triglyceride of 175, that is a pretty, very reliable estimate, predictor of heart disease. It has the biggest impact. The best estimate is a number range, that these don't add up to 100% because there's a lot of considerable overlap. Physical inactivity, I was very surprised by this. And every time I saw this, people are surprised. Physical inactivity is a predictor of coronary heart disease, and it's a very powerful predictor of coronary artery disease. Okay, and then blood pressure of higher than 140 or higher than 90 diastolic is also a very strong predictor of coronary artery disease. Cigarette smoking, especially in the young female, is a coronary heart disease. And then diabetes is synonymous with coronary disease. Actually, if you have type 2 diabetic, we would consider it almost equivalent to having a heart disease already, silent heart disease. And then obesity is also a contributor to heart disease. Okay, and then I have to go back one more thing. Being class of 88, anytime you have chest pain, you are at that age of, I would consider any kind of chest pain we have seriously. We would not, nobody would blame you for, crying wolf. Okay, so we're at that perfect age where we need to be careful about heart disease. So what do we do about it? So very few things that we can do. It's mainly it comprises of cholesterol control. So if you have LDL, very high LDL of 190, believe it or not, my LDL was close to that level already, even though I don't have a family history, but I was shocked. Basically, we try to lower your cholesterol as quickly and most robustly as possible. So we put you on a high dose statins, and then if you have diabetes, and when you have LDL that high, you will be on statins regardless. Okay, regardless of age, even if you're 20 years old, we have you on statins. And then if you have diabetes, that's automatically high risk. And if you're aged between 40 to 75, we would put you on moderate intensity statins. Statins are the HMGA-CoA reductase inhibitors. They're I'm going to talk about that on the next slide. It's our basically bread and butter medicines for lower cholesterol lowering. And then if you have renal disease or any kind of vascular disease, then we would automatically put you on high intensity statin. So if you have diabetes, like my wife has diabetes, and she should be on statin, no question. Okay. And then if you have LDL, 70 is very low. On average is about 100. And we have this thing called 10-year atherosclerotic cardiovascular disease risk calculator. And I would suggest you download it. And it's actually an app. And this is what we use in our clinic because it's so much simpler than all this complicated algorithm that these different societies do. But at the end, this is what we use. This is according to 2013 guidelines. You just punch it in, who you are, what your race is, and then you put your blood pressure, the latest cholesterol, and it calculates what your 10-year risk of heart attack is over the course of the next 10 years. And if it's greater than 20%, which is 2% chance of a heart attack each year, then we would consider that high risk, and we would put you on high intensity statin. And if you are at intermediate risk, which is mainly 1 to 2% a year, then we would consider moderate intensity. And if it's borderline risk, which is less than 1% a year, then it would depend on how you feel about it. And this is where I deviate from guideline quite a bit. I tend to start statins earlier than what the guidelines suggest, because guideline is very heavily driven by age. Okay, um, so most of my patients that come to me in their 50s don't qualify unless something horrible. They've already had a heart attack. They never meet the high risk criteria. And I get a sense that these calculators underestimate the true severity, because it's so the way I think of it is that coronary cardiovascular disease, atherosclerosis, is a chronic cumulative disease. Okay, so you don't develop at age 50. It began when you're 20 years old, and it accumulates over the course of decades. And so the whole point of high intensity risk is just high intensity statin is to lower cholesterol as much as possible. But I do think that the area under the curve is more just as important as the intensity of lowering. If you think about it, basically, that's why I tend to start earlier in my patients than trying to lower the cholesterol, try to lower it as much as I can. So another reason for this is that there are these patients with genetic mutations in PCSK9 or ApoC3 mutations. They're very rare mutations, and they don't have this gene for some reason, and they're perfectly fine. And their cholesterol level is not like really low; they're just moderately low, and they never develop coronary artery disease. And conversely, there are patients with a gain of function mutations in these mutations, where the cholesterol level is just high, like not super high, but it's high enough. But they're high throughout their life, starting early, and they tend to have high risk of coronary disease. And the point is that the risk of heart disease, protection or risk, elevated risk, is out of proportion to the degree of cholesterol abnormality. So what it tells me is that earlier you start, even if you lower it just a little bit, you're going to gain a big bang for your buck, because you're putting on a different. If you could see coronary disease as like a curve going up, you're actually changing the curvature a little bit, rate of rise a little bit, and over a course of time, you're going to have a greater impact when you're 50, 60 years old. And the whole idea is that you want to lower the risk by starting early. So I tend to be more aggressive on starting patients on statins, and I've already I take statins early. I've been taking it for about 10 years. And then the statin here is basically this. This is you might keep this for yourself and see which one you are on. I took out low intensity statin because like nobody's on it. It's sort of useless. And so medium and high intensity statins. And so this is what I just talked about in the previous thing. I like rosuvastatin the best, not because they pay me to say so, but Asian especially have this weird kind of we have some different genes in terms of P450 metabolism, and I took all these statins. I was on simvastatin, and I developed some muscle aches. I was on atorvastatin, and I was like, I was dying. I really felt like I had a flu for like forever. And then it turned out that it took me about a year to figure out that it was actually statin mediated. And so I was almost going to be on PCSK9 antibodies, the newer, very expensive versions. And then as last resort, I tried a rosuvastatin. And for some reason, it lowered my cholesterol very well, but I don't have symptoms of like muscle ache. Like, it's like I felt like somebody was sitting on my chest for like shoulders for about a year. And it came on so gradually. All my lab tests were normal, but I definitely felt it. And so I think it's a very common phenomenon among Asians. You rarely ever see that in Caucasians. But as a victim of statin mediated myopathy, I could say, if you feel the pain, go talk to your doctor and have the doctor put you on a different drug because something else may work. The triglyceride, there's a lot of talk on this called the SEPA that's actually on. It's mainly a fish oil hypothesis. It turned out the fish oil constituent didn't work, but an ethyl ester of a fish oil happens to work. And the idea is that for people with established coronary disease or type 2 diabetes with a high elevated fasting triglyceride, adding this on top of statins can actually prevent future events. It's really expensive, so I don't have that many people on it. Again, you might have heard this. Aspirin used to be recommended as a primary prevention, but it's no longer recommended as primary prevention, mainly because it causes a lot of gastric side effects and even hemorrhaging. So it's actually more harmful than good, it's decided. But if you are really worried about heart attack, I think aspirin may be good. It's not recommended, but you may want to take it. And the aspirin would be a baby aspirin, like 81 milligrams, not the full dose aspirin. And then influenza is a common trigger of heart attacks, tens of thousands of years. And in my maybe because I'm a cardiologist, it's a very common trigger of heart attacks. And so make sure that get your flu vaccine each year because we see this a lot. Because I don't really know why, but I think when you get a flu, you get this inflammatory response and it probably destabilizes the plaques that are already there. And so getting a flu vaccine will really help you from getting a heart attack. I'm going to talk about diabetes a little bit. And so, there's a higher incidence of diabetes in Native Americans, Hispanics, Blacks, and Asian Americans compared to non-Hispanic whites. The average for non-Hispanic Americans historically 7 to 8%. And Asian Americans are kind of crazy because there's literature saying we're like protected. They're like 4%. But the more recent data suggests that Asian Americans, especially Korean Americans, tend to have a really high incidence of diabetes. It's anywhere from 20 to 25%. That's extraordinarily high. That's like 3 times the white population. And it turns out the vast majority of Asian Americans are under treated for diabetes. Okay. And when you have diabetes, you're automatically high risk for coronary disease. And we would automatically put you on statins. And as a cardiologist, if I see somebody with diabetes and are not on statins, I would say get a new doctor. But the reality is that 92% of people with diabetes are not on statins. It's not guideline-based. It's not recommended. But after all, doctors are just humans. So it's a staggering how we're not following the rules. 92% are not on statins. And then there are new medications that are really good. But I could skip that. It's on the thing, but it lowers coronary disease and it prevents heart attack. And it turns out that they're actually good for patients with diabetics and in terms of preventing coronary risk factors. I'm going to finish up with a little bit on diet. Is it okay? Diet is something that's really hard, but it's very important. There's this thing called dietary approach to stop hypertension. There's a famous diet called DASH diet. And then there's a Mediterranean diet, low carb diet. There's actually, many different varieties of it. I'm going to talk about that a little bit. And then intermittent fasting. Diet is a very important component of our lifestyle modification. DASH diet, I don't know who's on DASH diet, but this is a FDA and NHLBI AHA approved diet. It's mainly comprises of portion control, just basically eating less, being moderate, and then variety of foods. Instead of eating one food same day every day, but mix it up a little bit. And primary benefit, I believe, is mainly sodium control. It's really, it's trying to regulate the sodium so that you get lower blood pressure. And the way I kind of think about it is that the DASH diet, if you actually look at it, it's a lot more fruits and vegetables than anybody else thinks is reasonable. You basically have to have 5 servings of fruits each day, plus 5 servings of vegetables each day. And then I ask you, like, how many of you does do this, right? So we have, so this diet is a very drastic diet. It's a lot more than what most people think it is. Okay, and a lot of it is common sense. Avoid processed foods, avoid restaurant foods, because salt is what people like. It's very tasty. So, if you go to a restaurant, they're all salty, and any processed food is also salty. And so, avoid those two foods. And the sodium is incredibly low sodium. Basically, it's about 1 teaspoon per entire day. So, basically, no sprinkle of added salt at all. No way. And then if something that you're about to have has about 500 milligrams sodium per serving, leave it at the store. And then this is you got to start looking at the serving sizes. I think a lot of the hamburgers that you might buy actually has quite a bit of sodium. And so the DASH diet is even though it's the most popularly prescribed diet, I can't take this because the food is pretty awful tasting because I like salt. And then there's a Mediterranean diet. And I think Mediterranean has been proven over and over again to be beneficial. It's mainly very minimal sweets. It's what Greeks and Italians might eat. A lot of whole grains and fruits and vegetables, and a lot of cooking on olive oil. There's something magic about olive oil, and a lot of fish, seafood, including shrimp, which has a high cholesterol. It's okay, and less and less of red meat. So this is a food pyramid, but it's mostly kind of starch, fruits, and olive oil based and fish based diet. And this is easy if you're from Mediterranean region, but not necessarily easy for everybody because it's slightly different. Okay. And then there's this thing called low carb diet. Basically, you're avoiding all kinds of sugars and all kinds of starches as much as you can, and you try to eat more fat diet, more protein based diet, and try to replace instead of in more green vegetables over root vegetables. Um, low. There's a lot of variation on low carb diet. You might have heard of Atkins diet, right? And keto diet. Atkins diet is just like meat-based diet, and it's a good way to lose weight because it turns out that if you eat fat, it turns out that vegetarians gain weight because vegetarians are always hungry, and what gives us satiety is actually fat and proteins. And so the Atkins diet is based on that concept. But if you think about it, Atkins died of a heart attack, right? He fell on an ice after a heart attack. So buyer be aware. And there's a lot of things about ketogenic diet. It's not proven, but I know a lot of cardiologists on it. But I've also had patients who I saw after a heart attack and they're on ketogenic diet. So I cannot endorse this. Basically, the whole point of this diet is that it's high fat diet, very low carb, and it looks just like what you see here. Vegetable comprises of mainly avocados, a lot of eggs, and a lot of bacon. I don't know. I mean, it's supposed to be good for you because it puts you on a different metabolic state and allows you to lose weight and burn calories better. And people swear by it. It's supposed to, lower your insulin levels, but it's been proven to make you lose weight. But the problem is that the weight loss may not last, and it comes with a lot of other side effects. So if you're interested in ketogenic diet, I have things that are listed here. No alcohol, like basically no starches, no potatoes, anything that comes out of the ground that you avoid, no carrots. And so I can't endorse it, but I know cardiologists who are on ketogenic diet and they swear by it. It's a little different than other diets in the sense that like DASH diet and low carb diet, it's it's really impossible to stay on. I think I don't know. So intermittent fasting is it's a claim to cause weight loss. It improves metabolic health and prevents longevity. I know that calorie restriction can extend life in all animals, whether it be um, mouse, rabbits, fish, fruit flies, and worms even. So this is where the concept comes from. The confusion is that there are many varieties. I think the most popular is 16 to 8 method. It's where you fast for 16 hours a day. So every day you're fasting. And you do that by eating between noon and 8 or whatever the variety so that you're fasting for 16 hours a day throughout the day. And the easy way to do this is actually skip breakfast and 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 then not have a late meal. So, it turns out that we're grazers. So if the food is in front of us, we just tend to eat. But just the idea is just limit yourself to that 8 hour period in the day where you're allowed to eat. You could eat normally, but don't eat outside that window. And the idea is that you're constantly resetting the clock for metabolic clock so that your body is thinking that you're fasting. Another one is you fast 2 times a day. And it's not a hard fast because you could eat about 600 calories a day. That's about 1/4 of typical diet. A typical candy bar is about 150 to 200 calories. So, a couple candy bars a day during the fasting days. And then there's another one where you do don't eat anything, eat, stop, eat, and basically do a 24-hour true fasting once or twice a week. Just keep a day where you don't eat. Okay, like maybe on weekend or Monday you don't eat. And then another one is alternating fasting. So you eat normally one day, next day don't eat as much. And this is easier to remember because then this today I eat, tomorrow I don't eat. It's just a more regular routine. And then there's a thing called warrior diet where you fast during the day, you don't eat anything, um, maybe a small vegetables, and then eat a huge meal at the end at night. I'm not sure. I'm not sure whether that's such a good idea, but people do lose weight on that diet. Um, I like 16/8 because it's most it's most realistic and more reasonable than any of these diets, and it's not diet. And at the end of the day, which diet is right for you? Other than the ketogenic diet, which I do not endorse, at the end, it all depends on what you can stick with. Because the hardest part of diet is actually sticking with the diet, not the diet itself. Uh, that's my recommendation. And then finally, the exercise is very important. As you know, exercise inactivity is a major risk factor for heart attack. And so there's this thing called 7 minute workout app I would recommend. Um, it turns out that diet and exercise can prevent diabetes. So there are many different. I didn't realize this, but there are many different types of 7 minute workout apps. But what you should get is official Johnson and Johnson 7 minute workout app, mainly because that's free and it doesn't come with like these advertisements and subscriptions and things like that. It gives you like the jumping jacks for like 30 minutes, 30 seconds, very simple exercises that you could do in 7 minutes throughout the day. And this will be enough to improve your cardiovascular health. I mean, if you're like, this is good for me because I'm relatively inactive. But if you're already a very vigorous person, 7 minute workout is not for you. But this is for vast majority of my patients. It's a reasonable approach to lose weight and keep your health healthy.